Jacqueline, are we ready to begin?
Yeah.
Thank you. Good afternoon. My name is Gina, and I am the president of the Pregnancy Loss and Infant Death Alliance, and I want to welcome you today to PLIDA's quarterly webinar series, one of the multiple opportunities to enhance our practices that we pick so dearly. In May, PLIDA hosts the International Perinatal Bereavement Conference in beautiful New Orleans, Louisiana. I hope you will join us there May 13th through 16th. However, today, it is my honor and privilege to introduce you to Alexandra Patch. Alec works as a research nurse coordinator at UT Health Houston Fetal Center with the Division of Fetal Intervention. There is so much trauma and loss and grief when there is a finding that a baby has an abnormal diagnosis requiring a higher level of care and expertise that really only a fetal center can provide. Even more challenging is providing seamless care across multiple service lines and institutions. Oftentimes, the fetal center may not really be necessary. They may be a completely separate entity from the hospital where these families deliver. Even Alex and her team partner with others to provide care and support across the continuum: fetal center, antepartum, labor and delivery, and the NICU. And I have been very fortunate to walk alongside Alex and bear witness to the great work she does. Her and her team provide care and support across all those continuums, and it has been transforming for our families with very high-risk pregnancies. And so understanding the journey of these families provides us the ability to provide comprehensive care and support, understanding where they started when they first got that diagnosis and that pregnancy got seen through an extremely different lens. Helps us on my side, where I work in the NICU, to really kind of know the journey this family's been on so that I can better support and care for them. And with that, I'd like to introduce Alex.
Thank you, Gina. I appreciate it. It's always a pleasure working with you. We're very fortunate. And thank you all for joining this webinar today. So my name is Alex. I am a registered nurse. I have been a nurse for, oh my gosh, 15 years now. And I've been working with the fetal center on and off for about the last 8 years. So if you want to go to the next slide. Um, just a little bit about me. I was born and raised in Vermont, which is in the New England area. I graduated from the University of Vermont with my Bachelor of Science in Professional Nursing, history of volunteering, with Girl Scouts, 4-H, and after I graduated college, I worked at Dartmouth Hitchcock Medical Center for 4 years in New Hampshire. My original goal was always to work with, moms and babies. When I started out as a nurse, I figured med surg was, the best path to start for me just to gain some more experience. But, in our area, a lot of these like really high risk, complicated patients, with fetal conditions, some of them, they may have to be transported to, Boston Children's and go from there. So go ahead to next slide. So with a limited knowledge, about, fetal diagnosis and intervention, I eventually decided to move to Houston, Texas, just for better job opportunities, warmer weather, which it's very, very warm down here, warmer than I planned on. But I was fortunate enough to be able to get a job in the Texas Medical Center. So we call it TMC in Houston, Texas. It's considered the largest medical complex in the world. They see over 10 million patients encounters annually. So with my role at the fetal center, we are with the UT Health Houston, as well as an affiliation with the Children's Memorial Hermann Hospital. Okay, and next slide. So who we are a multidisciplinary team, with board certified specialists. We manage complex fetal diagnoses during pregnancy. We provide the highest level of evidence-based, patient-centered care to families, not just here, but internationally, through collaboration, innovation, and research. And when it says we're available 24 hours a day, 7 days a week, we are. We are based in an outpatient clinic. We have clinic hours Monday through Friday from 8 to 5. But due to the complexity and severity of some of these conditions, we always have an on-call physician, an on-call nurse. We see patients in and out of the hospital in the middle of the night, on the weekends, holidays. So if we are needed, we are there. And the best part about working with this team is that we take care of patients who are probably experiencing one of the worst days that they will ever experience. Most of them, they find out they're pregnant, they're very excited, they go in for a scan and they find out that something is wrong. And immediately the anxiety, stress, and worry starts. And so no one really expects that they will ever need to come see us or want to come see us. But we are here, for patients when they're in their time of need. Um, okay. So who we are includes, but not limited to, we have our fetal interventionalists, maternal fetal medicine specialists, cardiology, as well as all of our pediatric subspecialty providers. We are also ultrasonographers, echosonographers, genetic counselors, nurses, MAs, physician assistants. We have a full research team. Very important, our insurance verification specialists. We are fortunate enough now we have a social worker, um, and there's just so many people that make up our team that, every role, every person plays an integral part of taking care of our patients. Some patients even we hand out business cards to all of our patients, and some even will have a binder full of everybody they met along the way through their fetal center journey, but they know who to contact, when they need something because we are all specialize in different areas. Okay. So what we do, so at our fetal center, we offer a complete range of coordinated care for pregnant patients before, during, and after birth. So this can include comprehensive imaging, primarily ultrasound. We also offer fetal echocardiograms and fetal MRI when necessary. Um, we also offer consultations with our fetal specialists as well as our MFM team, pediatric specialties. Basically, the consults are tailored to each patient's unique diagnoses. Each patient gets a dedicated nurse coordinator assigned, and so they are the primary source of contact for these patients from the first phone call when we get the referral, to confirming appointments, confirming plan of care, and follow-up. We also have a comprehensive genetic counseling team um, where a majority of our patients will receive genetic counseling, um, especially regards to, some conditions with future pregnancies and hereditary conditions. Is this something that I carry that I could pass on to, future children? And we do offer, all forms of invasive genetic testing and non-invasive testing as well. And also importantly, educational resources about short-term and long-term follow-up care, for the patient and for their baby. Um, let's see. And we also partner, like I said, patients, depending on their diagnosis or findings, with the appropriate pediatric specialists that will do a prenatal consult and then follow that patient through delivery so that they can see those kiddos, after they're born to make sure they get the correct follow-up and treatment. And I included just a brief snapshot of some of the fetal conditions that we treat or diagnose, but this is by no means a full list. There's hundreds of diagnoses and findings. Okay. All right. So, also part of what we do is surgeries and procedures. So, this is something I had never heard of before until I started working at the fetal center, is that we do in utero surgeries and in utero procedures, whether it's needle-based, fetoscopic, and open, while the mom is still pregnant. And some examples of these include, spina bifida, myelomeningocele, um,
Yeah.
placental laser ablations for twin-to-twin transfusion syndrome, We offer shunt placements for, bladder and thoracic areas. We do intrauterine blood transfusions, coordinated deliveries, and many, many more. We also offer comprehensive maternal care. So for patients that need to completely transfer their care to us to deliver at our facility, you have the fetal center that's helping manage the fetal diagnosis and condition and imaging, but also too, we now have a full service team that takes care of mom and all of her prenatal needs and helping with delivery coordination and planning. And then our most multidisciplinary team approach. As you can see on the previous slides, we really work with a lot of different specialists to help collaborate the best plan of care and help the patient feel supported.
Right.
Um,
She's not
okay,
available?
next slide.
Her name again?
Okay, and this is just, a reminder of why we do what we do. We do what we can to provide, the best possible outcome for all of our patients.
Class
We want to
until.
help the best we can, whether that's, information sharing, support, um, and especially for some of our research, studies and interventions, we follow these babies and children all the way out until like 6 years of age. So our fetoscopic spina bifida surgery, what I learned in school was a lot of babies with spina bifida have a lot of complications and often, don't even make it very far past birth. Well, now, we're offering a in utero procedure that can help the babies have a better, outlook, a better chance of walking and meeting those developmental milestones. For twin to twin transfusion, for identical twins, we can offer a laser procedure that helps try to protect both twins, to give them the best outcome. And so, a lot of what we do is just to try to help, support our patients, get them the best outcome possible. Of course, there are some conditions or diagnoses that all we can really do is just, offer support and, planning for birth and afterwards. But we just try to help, our patients make informed decisions and support them on whatever path they choose. Okay. So one size does not fit all. So the definition of a fetal center actually varies. Every fetal center is unique. Ideally, each fetal center would have accessibility to the highest level of maternal, neonatal, and pediatric care, considered a tertiary care facility. Ideally, both maternal and neonatal slash pediatric would be within the same facility, but there are some that do have to, go across the street or, transfer to the next building. Also, the years of training and experience vary. Accessibility to specialized staff, available interventions and procedures. Some centers only offer certain interventions or procedures because others, they either don't have the training or they just don't see enough patients with that diagnosis to have the practice of performing. And some of it just comes down to, technology and then also to academia, education, and research. There are fetal centers located all over, not just North America, but all over the world. Some states and cities have more than one center, like here in Houston and in Texas, and some states do not have any. And then some common barriers for our patients to get to a fetal center or get to what they need is the availability of the specialists, interventions offered at facilities, levels of care needed for both mom and baby, and the big one, insurance. As we all know, there's, in today's current healthcare system, insurance can be a big barrier because it may be in network for certain places and not others. It may cover certain procedures and not others. There are still some interventions and things that are offered that are under research still, and some insurance companies, may not approve that procedure or they need to go somewhere else within network. So, and those are for patients that have insurance. Okay, next slide. So this slide here is a quick snapshot of where a majority of our referrals have come from in the past couple of years. We have received a referral or two from Alaska and Hawaii, as well as international, but this is all I could fit in one slide. But as you can see, where the star is we are located here in Texas. Primarily, our referrals come from all over the Texas area, but also the bordering states like Louisiana, Mississippi, Oklahoma. We do get a handful from the Northwest, as well as the Midwest. And patients arrive, planes, trains, automobiles. Some patients drive all the way to see us, others fly. Unfortunately, some may have to be transported by ambulance or life flight. Um, and next slide. So an example of that is the Duggar family, and I wanted to share this story because I remember this family. And so this couple is from California. They were expecting identical twin boys. They were being screened frequently for what we call twin-to-twin transfusion syndrome. And come to find out, one of the twin boys, Rand, actually had bilateral renal agenesis. So his kidneys had not formed and was not producing any amniotic fluid. So the Duggar family, they went to a couple of places in California to seek care, but because at the time they weren't reaching the level of twin-to-twin transfusion syndrome for intervention, um, they reached out to us as another opinion to see what we could do. And by the time the family got to us, she actually had developed a rarer form of twin-to-twin transfusion called TAPS, and twin anemia polycythemia sequence. And we actually were able to help and offer the laser procedure because the parents' ultimate goal was ideally to have both boys, be born together and alive so that they could at least spend some time together as a family, even though Rand's condition is considered lethal. His kidneys were not developed, he's not making any amniotic fluid, and his lungs will not develop appropriately. So this family came all the way, to see us for intervention. And the patient herself said, I was willing to fly anywhere in the world if somebody could help. Um, and luckily we were able to help them. And both boys actually were born alive together. Um, the co-twin did have to go to the NICU for some time, but the Duggars were able to spend a whole 58 minutes with Rand before he passed. They got to hold him, and she said, I've never sent as many I love yous as I have in 58 minutes. But they were able to be, a family all together, and that was ultimately what was most important for them. Okay, next slide. Okay, so starting from the beginning, essentially, how a patient gets to us is, initially they get their confirmation of pregnancy with their OB-GYN provider, whether that's their OB or midwife, by ultrasound and lab work. And at some point along the way, there's an abnormality or concern found on ultrasound. Now, typically, a majority of the patients we see, these concerns are found during their comprehensive anatomy scan, which is between 18 to 22 weeks gestation and is the ideal, time frame where we can see everything from head to toe on the baby. We have seen patients sooner, within their first trimester, or if they get a basic anatomy scan. Some we've even seen in the third trimester because these concerns were not showing up initially on their comprehensive anatomy scan. And then typically the OB-GYN provider will refer to a maternal fetal medicine specialist for further diagnostic imaging and counseling. And then once that concern is confirmed by maternal fetal medicine and needs a higher level of care and consultation, they then refer to us. So by the time the patient reaches us, they've often seen at least two providers already. Okay, next slide. So this is just showing a couple of different pathways of how patients can get to our center. Typically, like I mentioned, the patient's seen by their OB-GYN, and then the OB-GYN then refers to MFM. There are some OB-GYNs that send their patients to radiology still for all of their ultrasounds, so sometimes it's picked up by radiology. Some OB-GYNs perform their own comprehensive anatomy scans, and others refer directly to MFM to perform this anatomy scan. So there's multiple different routes, but at the end of the day, that's an abnormal ultrasound finding, and they most likely will need to come to the fetal center. Fortunately, there are some maternal fetal medicine specialists that, depending on the severity of the condition, they can manage the patient or co-manage the patient along with their OB provider if they have the appropriate level of care at their intended delivery facility. And best case scenario, sometimes these suspicious findings resolve. Um, or they are not confirmed and it ends up being normal and they can go on to have a routine pregnancy, but at the end of the day, for any concerns outside of that, they come to us. Okay. And not to mention, with the pregnancy journey, there are some patients that have undergone fertility treatments, including IVF, surrogacy. They may have a history of prior pregnancy complications, prior loss, medical conditions, including, mental health, um, certain family dynamics, and, the pregnancy may be, unplanned or unexpected. And so there may be a lot of factors, with every patient's journey before they even get to their anatomy scan as well. So there's just a lot of things to consider, when it comes to the patient and their expectations and the care that they'll need. Okay. So yes, it is complicated. And if there are any Office fans out there, I showed this picture of Dwight presenting his org chart, because as I was looking, trying to put together that visual of the patient journey and how they could get to us, there's a lot of like zigging and zagging, and there's not a clear-cut standard pathway for any patient. And so the process itself before they even get to us can be very complicated. Okay. So referral process, we primarily get referrals from the patient's provider, ideally, because we are considered a referral center or specialist. So for most insurance companies, they do require a referral in place, whether it's by fax. We do have an online option to submit referrals. Sometimes we just get phone calls, in person or walk-ins or in-house consults. We have also received referrals from other fetal centers, depending, if the patient needs a procedure that they don't offer or the patient doesn't meet their criteria. We do get self-referrals. Patients find out about us through social media, word of mouth, and then our recent marketing campaign, Dr. Papana, he specializes in the spina bifida repair and follow-up. That's a picture of him on one of our buses through the medical center. So we have gotten a couple of calls from patients saying, "Oh, I saw your doctor on the bus," or "I saw your doctor on the billboard or at the airport." So we get calls from all over the place. Okay. So once the patient gets their appointment, part of the initial evaluation process is a majority of these patients will need an ultrasound. Some may need an echocardiogram for suspected heart condition, and occasionally fetal MRI. Some patients may be here for invasive genetic testing or considering. And then, depending on the suspected diagnosis, we offer consultations as well. Every patient that comes for imaging will have a consult with a specialist. And the fetal specialists, I put an asterisk because our fetal specialists are MFM board certified physicians, but they have completed extra training in fetal diagnoses and intervention. And then we also partner with neonatology, our NICU providers, as well as chronic and palliative care services, our CAPS team. Some patients come directly to us for conditions like anencephaly, or other lethal conditions, and they just need help understanding, what the next steps are going to be and to help create, a birth plan and to get that early support for when the delivery time comes and how to support the family as well. So some possible post-evaluation scenarios, oftentimes the suspected anomalies or conditions are confirmed. Next steps depend on the severity of the diagnoses, patient wishes. There are occasions where we see the patient and we're not able to confirm the findings, which is great. We can reassure them that everything seems to be normal, but if anything they find out further along the way, we're always here. Um, some findings may be associated with a suspected diagnosis, but they do require postnatal assessment to confirm. So there are some conditions where, unfortunately, for our patients, we can only tell them what we think is going on, but we cannot know for certain until after the baby is born. And there are some that the anomalies are more severe or complex than expected. We've had that happen quite a bit, where only so much is seen on the anatomy scan, and then they come to us and we find out that it's a lot more significant than expected. And on the rare occasion, we have had some patients, and because of the severity of everything, that the baby may have already passed, and then we help support them figure out the plan of where they would like to deliver and coordinate with their primary team. Okay. Um, so for a lot of our patients, we always say it's more than just a diagnosis. And that is because, especially in pregnancy, it's not, just the mom, but it's also the baby, and it's not just the baby, it's also the mom. So for the mom, we're concerned about prenatal care, labor and delivery, and the postpartum periods. And then for the baby, it's anticipated NICU stay, specialty consults, surgery, treatment, postnatal follow-up. And then, of course, we also, are family centered. So, the patient's partner or spouse, other children, family, friends, and support. Okay. Okay. So, what happens next? For a lot of our patients and families, that includes anxiety, depression, anger, fear, avoidance, grief. And I included some quotes from some research articles that I love. And essentially, the prenatal diagnosis of a fetal anomaly is unexpected. And for many parents, it's devastating. It is considered a traumatic perinatal event that presents a crisis for parents. And that it takes time to think about the reality of the news and sort through the emotions associated with hearing that the expected normal pregnancy is not going to take place. Okay. And then this is another patient example of this. So the Gonzalez family, they were expecting their first baby, and the Casey had already gone through a rough, first trimester with hyperemesis. And then again, when it came time for the anatomy scan, they were told that their baby was severely growth restricted and did not have much fluid. And so they came to us for further evaluation and ended up transferring their care and were hospitalized early on in the pregnancy. This family desired every intervention available, and due to the severity of the growth restriction and low fluid, she needed constant, frequent monitoring. So this family is a great example of our patients that have not only a complicated pregnancy, but a complicated hospitalization. She was admitted at 28 weeks and was in the hospital for at least 2 months. And her husband basically moved in with her and was sleeping next to her on an air mattress. And, Casey was quoted, "When you're in the hospital for that long, you have to find some joy in it or you'll lose your mind." And they would go on little dates together, try to make this like their new normal. But also collaborating with the hospital side. Our team would go see her. And the hospital service staff, were wonderful. They helped her decorate her room, prepare her for, delivery and the NICU stay. And fortunately, they had a great outcome. As you can see, baby Rylan is thriving. But ultimately, this family went through a lot of stress and anxiety, but it really took, the whole team to come together and help support this family through their journey. Okay. All right. So after the initial evaluation, some patients may need extra imaging, further genetic testing, frequent monitoring. They may need to transfer their care over completely. They may need to see a pediatric specialist consult or multiple consults. Um, as well as mental health counseling and support. So every patient gets a comprehensive plan of care, like I mentioned, a dedicated nurse coordinator and a multidisciplinary team approach for their further plan of care, whether they stay with us or go back to their primary care providers. Okay. So for those patients that need to completely transfer their prenatal care, it's because they need a higher level of care, access to level 4 NICU, pediatric specialists, and also, a higher level for maternal care. Their care is transferred from their primary OB over to the fetal center for the duration of their pregnancy. And we help them plan and coordinate from clinic to hospital, from delivery room to NICU, and then from NICU to home. But the ultimate goals are to keep, the mom and baby, they get to stay together in the same facility, and that there's a continuity of care with the maternal and pediatric care teams. Okay. So one of the complications, if you will, along with this journey is, the evolution of our electronic health record systems. So, here at our center, we are a separate entity from the hospital. So we have an academic affiliation, but the UT Physicians Clinic side has their own electronic healthcare record, as well as Memorial Hermann Hospital. So it has taken some time for both centers to partner up with the same system. But prior to 2021, when we went go live with Epic on the clinic side, we had a separate application for scheduling, a separate application for EHR. We have a separate application for imaging, which is where all of our imaging reports and consult notes went, and also an independent database. And then at the hospital, they had a completely different electronic healthcare record system, than we did. So, we put a lot of, time and effort and thought into creating these plans of cares for our patients. But at the end of the day, we needed to find a way to relay that information to the hospital side, to the pediatric specialist, to the NICU team, to the labor and delivery team, and to all of our supportive services. And so there was a lot of coordination involved. There were times where we did have to run records over to the hospital, plans of care over to the hospital, try to upload records, into the computer system. Um, and it took a lot of communication and partnership. Fortunately, now, since 2024, both of our clinic side and hospital are both live with Epic. On our side, our imaging application, scheduling, and medical records is all in one system and it interfaces with our imaging application. And then that gets synced up with the hospital as well. And so it's a lot easier now for everybody to follow these patients because the last thing we want is a patient to show up and they need to be acknowledged as a fetal center patient. They've gone through this incredible journey already, and the last thing they want is to feel like, they have to start their story over again and, figure out what their needs are going to be. Okay. So, the maternal care program, so this was developed in 2019 by Dr. Refuerzo. She is one of our maternal fetal medicine specialists that has a passion for, maternal care and mental health. So prior to 2019, any patients that needed to completely transfer their prenatal care would be transferred to our OB partners, across the hall. So again, the patient has a separate OB appointment, and then they come to the fetal center, and then we all have to try to coordinate the plan for delivery and then coordinate with the hospital. So Dr. Refuerzo felt that we could improve this by having a in-house, so within the fetal center, our own prenatal care program. And not only that, but she has the level of expertise as a maternal fetal medicine specialist that so she can also help manage and treat high risk maternal conditions like diabetes, lupus, hypertension. Now we're even seeing oncology patients. And so her ultimate goal is that, to take the best care of, the mom during pregnancy, while the fetal center, helps take care of, the imaging and coordination. Um, and also to meet the patient's emotional needs as well. We have really built a close collaboration with our mental health specialists, as well as the Journey program, which I'll discuss in the next slide, about how we can help better support these patients and families on an emotional level. Okay. So the Journey program was started, prior to COVID, and it involved, our labor and delivery women's services team for antepartum, L&D, and postpartum, our NICU team, child life art therapy, music therapy, chaplaincy, and we have a March of Dimes representative, and in our CAP service. And so they did an excellent job of supporting the patients during their hospital stay, during delivery, and during the NICU. But there was a gap between accessing these services, on the fetal center side while the patient is still pregnant and is undergoing this unexpected journey during their pregnancy. So around 2021, as things with COVID were starting to wind down, we all came together to see how we could best support these patients from the beginning, from when the patient gets to us at the fetal center, so that these families don't have to wait until it's time for them to go to the hospital, to have access to all these wonderful, services, and to get that early intervention and acknowledgement, to decrease anxiety and provide a sense of community for these patients and families. Okay. And so to bridge the gap, the Journey team, we all came together and we are able to offer personalized labor and delivery as well as NICU tours for our patients, based off their diagnoses, their history, other children, and early access to supportive services like child life. That's been hugely helpful for us. We offer weekly sessions. Each week is led by a different team. And the goal is to help minimize stress, anxiety, isolation, and to meet the patients, where they're at. And it's also a great way for other patients to meet, others going through a similar unexpected journey and to build that community. And to hear about where others are at their different, stages, whether they're, in-house on antepartum, or their babies are in the NICU. Okay. So long-term outcomes and goals. Um, you know, One of our big focuses right now, is, maternal mental health, for patients that experience a pregnancy loss, a traumatic birth, even those that just, undergo a fetal center pregnancy, and their babies may have a, NICU stay. Um, we want to look more into that. We see a lot of patients that come back to us for future pregnancies, and they come back because we know their story, we know their journey, we understand what they've gone through before, and there is a higher level of stress and anxiety, in these subsequent pregnancies. And so we are starting to research those areas and help build out a more comprehensive maternal mental health program. Um, we're looking into screening anxiety and depression for these patients that come back to us, and then look at the outcomes of how it impacts their future pregnancies. And so, like I mentioned, we've partnered with our psychiatry, and counseling services and offer early screenings, to assess these patients and help offer early intervention if necessary. All right. And that is the end of my presentation. And this is just a quick snapshot of just a part of our team, at Christmas. So you can kind of see, all the different team members, and we love to come together. And at the end of the day, we're just here to support our patients and families the best we can. And we all love what we do. Okay. So if it's okay, I'm happy to open the floor to any, questions or comments. for anyone out there, I'm happy to answer any questions or.
Hi, my name's Ruth. I'm from California. Thank you so much for your
Hi,
presentation.
thank you.
Yeah, I love all of the like collaborative partnerships that you guys are doing just to
Hmm.
provide like the families whole patient care. And so I work a
Hmm.
lot with expecting parents or, folks that have already had some kind of reproductive loss
Hmm.
and grief. So I'm just curious, like, if I had a patient
Hmm.
from the mental health side, because I'm a therapist,
Uh-huh.
that wanted to learn about a center, would they just talk to their primary care doctor? To learn about like a local place here or like how would
Hmm.
they go about finding one locally?
Yeah, so locally, ideally, they would go to their primary, pregnancy provider, whether that's an OB or midwife. But chances are, if there's already expecting some sort of complications, most likely they would go to see a maternal fetal medicine specialist. But like I mentioned, we have some patients that they go right online, they look up and just start Googling like, the condition and what centers treat that. And so, we do try to empower patients as well you know, to do that. I mean, at the end of the day, it's their it's their life and their pregnancy, and it's okay to ask for more information. And so if you're not able to find what you need in your local area, to look online, look at other centers, look at the reviews and go to their website and see if, they offer treatment or monitoring for the conditions and to make some phone calls. A majority of the centers, like I said, it's either a nurse or clinic coordinator, that will answer, and we're happy to talk to anybody. Really? Yeah.
Yes, and I saw that like self-advocacy. I thought that was awesome where it said clients can self-refer and so
Hmm.
they can go that route then even if they like talk to their primary care and they're not maybe in support of making that referral for
Hmm.
them, then they can do it themselves then.
Yeah, yeah, they
Okay.
can. So we have had some patients where that has happened, or they just wanted to come to us for a second opinion, and as long as, we're able to work with the insurance company, and oftentimes we have been able to, because as long as there's like a diagnosis, we've been able to do that. So, I mean, we do try our best to work collaboratively with the referring providers, but, if the patient ends up coming on their own, we're still able to try to help see them or at least guide them to maybe another center that may be closer to home for them that we know of. So the network is pretty big, as far as the fetal intervention diagnoses goes, because it is a very specialized area. And so a lot of our team members, we know people all over the country and all over the world. And so, if we think that we can help a patient find care closer to home, so they don't have to make the long distance, we can also connect them with other centers as well. Yeah. And what is your role? I know you said that you work with is it mental health support?
Yeah, I'm a clinical supervisor and also a licensed marriage and family therapist. So I see,
Wonderful.
yeah, I see individuals and couples.
Yeah.
So, and is the best place for them to find you, is that by looking up the UT Health, not the Memorial Hermann, or could they find you
Mhm.
either way?
They can find us either way. We
Okay.
do have on both institutions. We both There's a page for the fetal center.
Okay.
Mhm.
Great. Thank you.
Yeah, absolutely. Okay. Any other questions or any other folks listening in that are from other fetal centers?
I looked all over the sheet.
Okay.
Okay, one of the things, this is Gina again. One of the things I obviously work with Alex and have seen firsthand the impact that their team working with these families has had, and how grateful we are on our side. It used to be when you would
Mhm.
get a tour, you wouldn't know what the diagnosis was. Now we know when they show up what it is. It could be a
Mhm.
trisomy, it could be an omphalocele, it could be any of those things. So we already know that information. They don't have to tell that story over again. And we
Yeah.
can tailor the tour to what their baby's diagnosis is. The other thing that I
Mhm.
think is really critical here is I think once you get that diagnosis, your pregnancy is viewed through an entirely different lens. And what we
Mm-hmm.
have tried to partner with the fetal center to do is redirect that conversation back to the mother-baby relationship, and not,
Yes.
oh, your baby's a gastroschisis or your baby's an omphalocele. It's
Mm-hmm.
no, you have a son or daughter and your mom
Mm-hmm.
and your dad. And so I think there's been a lot of work about, like she said, supporting with child life, art therapy,
Mm-hmm.
doing all of these things to just support the entire unit.
Yes,
So,
absolutely. And we have some patients that, and we've learned along the way, they, no matter what is going on, this is their son, this is their daughter, and they have a name, and this family had, goals and dreams and hopes for this baby, and that may have been altered, but this is still their baby. And so we do the best we can to, connect with our patients and ask them, like, do you have a name picked out? What's the meaning behind the name? And, and they tell us about their families. And we get asked, I had one patient, I said, do you have any questions? And she goes, well, people at work, they know I'm pregnant. They don't know what's going on in the pregnancy. I haven't told them, but they want to throw me a baby shower. What do I do? What do I say? I mean, this is the reality for these patients. And, I kind of was taken aback, like, oh, and I sat her down and we talked about it and, helped her make a plan for her to feel comfortable communicating with her coworkers. Some patients, their families aren't aware of what's going on because the families don't yet know what they want to do. So, it's really important that, we connect with them on that level, but also to, partner, with the hospital services like Child Life. They help a lot of our families, like how to talk to their other children at home. They may have kids that they know they're old enough to know what's going on. And, well, why can't my baby brother or sister come home right away? Like, why do they have to stay in the hospital? Why do they need surgery? Why do they look like that? And our child life specialists can help these families, have these conversations with their kids and families. And, most importantly, promote the bonding process if that is what, the patient wishes to continue, and let them know that it's okay. We're happy to meet them where they're at, but to acknowledge what they're going through. It's more than just a diagnosis. This could change, the rest of their life. And I know, like Ruth, in your role, like it can hugely impact a marriage. We've had, you know, patient and spouse not agree on the plan of care. They may be at different, parts of the spectrum as far as the grieving process goes. You know, the spouse may be angry and frustrated, and then the patient could be sad. And then how do they communicate with each other and come together? So all of these are really important, factors, but this can be life changing. And so we try to acknowledge and best support that as we can. It's more than just a diagnosis. It's more than just a treatment. And it's a long journey. It's not just till delivery. We always say every pregnancy ends, but then there's the afterbirth journey, there's the postpartum period, and then there's the next pregnancy for some. So this is all, on a continuum. Yeah.
any other questions for Alex? Go
Alex,
ahead.
I I'm
Hi.
Innie. I'm with the Riley Fetal Center here in Indianapolis, Indiana. And
Great, great.
so sorry.
Welcome.
I told my team I failed with this time change and different time
It's
zones. And I was
okay.
like thinking it was 4 o'clock, and I was like, I'm just gonna get on early. But
Yeah,
I'm so sad that I missed most of it, but I'm super excited and look forward to watch the recording. But
sure.
I feel like there was just so much in the last 2 or 3 slides that you shared. So I just
Yeah.
thank you for doing this. I think it's so important. And like you said, it's more than a diagnosis for these
Hmm.
families. And I think when you're talking about husbands and wives being on different
Hmm.
pages, I remember I shared with a family, men and women sometimes grieve differently. Everyone has
Yeah.
different griefs. And afterwards, a patient just had happened to call and was giving me an update. And she was like, I'm so thankful that you talked about that because my dad was over and he was mowing the lawn, fixing doors, like, and I was getting ready to yell at him, just sit down. And I remember
Yeah.
you said about the differences in grieving. I was like, she was
Yeah.
like, I need to let him grieve. And so, like, it's just amazing that, how much what you said is so impactful. And so I
Yeah,
just want to thank you for giving this talk and
thank
presenting
you.
it.
And thank you for sharing. And yes, and a lot of us, like a lot of us fetal centers, we are connected. And I'm not sure if your center is partnered through NAFNA, but we do all collaborate with each other. And we even have our own fetal therapy, nurse network. And so we connect with other centers all over the country, because, what we do is so specialized, but it's important that we all still work together and learn from each other and share, these shared experiences. Um, but yeah, a lot of this, there's no like manual, for this per se. And fortunately, through our hospital, in Gina, we utilize the Resolve Through Sharing program. They have incredible educational materials and pamphlets, and we've used them in like how to talk to your kids, how to talk to your family, you know, what to expect when you're miscarrying and future pregnancies, and how to talk to your partner. So there are some wonderful education, materials out there too to help with these sort and trainings. But a lot of what we learn is from personal experience and from hearing our patient stories. Real quick, one thing I'll never forget is, this was just post-COVID, and we were restarting the NICU tours again. And a lot of our patients they seem to be excited about getting the NICU tour. They get to go over there and figure everything out. And one of our patients, she was enrolled in our RAFT trial. So her baby did have absent kidneys, and we were doing serial amnio infusions. And I asked her, I said, "Oh, did you enjoy your NICU tour?" And she looks at me and she goes, "Well, I didn't enjoy it, but I did get a lot out of it." And it really put things into perspective for me. And she was able to visualize and see and hear everything in the NICU. Um, so she knew what to expect. But it was so funny because she goes, "Well, I didn't enjoy it. It wasn't fun, but it was very helpful." And it made me rethink and reframe about, how you might ask a patient, a question, because it's not exciting to think that your baby has to go to the NICU. So at the end of the day, those are the most valuable feedback is coming directly from our patients too and their families. Yeah. Andrea, did you have a question as well? I saw you raise your hand earlier. Yeah.
Yeah, thank you. And I hope this is not too complicated because I know we have a little
Uh-huh.
bit. So I'm calling in from Canada,
Great.
Ottawa. Yeah. And I come to this call as a bereaved parent. I lost
Okay.
my son at 25 weeks.
Oh.
And my experience, I would have loved to have something like
Mm-hmm.
this in my experience because it was
Yeah.
so disjointed, and it ended up being a lot of me having to do like the
Yeah.
research. Where can I find these services? As
Mm-hmm.
simple as, follow-ups or grief counseling or
Yeah.
whatever. And to have that all in one place is like it's a dream in a worst case scenario. But I had a question. So
Mm-hmm.
this might be complicated and I don't know all the ins and
Okay.
outs.
That's
Everything
okay. Go
about
ahead.
because I'm only familiar with our Canadian healthcare system. But
Sure.
my after we had my diagnosis, we did opted for a termination.
Okay.
And I know that it's a bit complicated in terms of legislation in the States of,
Yes.
at what weeks can be considered this. And I just wondered what support you could provide
Mm-hmm.
to parents that would want that choice.
Mm-hmm.
Because it's well, I shouldn't even say choice. It's,
Yeah.
you know,
It's yeah. 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 Of course.
impossible decision either way.
Of course.
Um, so I just was wondering if that's something that your center
Mm-hmm.
can support, or
Mm-hmm.
what would happen in that scenario.
Yeah, of course. And that's a great question. And I'm glad you asked because out of all the states, I live in Texas. And so Texas, essentially, it's really, really not an option at this point. And, you know, on our side of things, we do have to discuss with the patient, all of the available options. And, for those that do choose to continue, with the medical interruption procedure, and of course, like we can talk to them and about that and have those conversations. Unfortunately, we cannot offer, anything here in the state, but we, can recommend, support groups and things like that. And, just try to help, it's a very fine line that, we are teetering on, being in this state and with the laws and restrictions in place. But at the end of the day, all we can do is just provide the patient with all of the information and support them, no matter what they decide. Because we acknowledge and recognize that this is not a decision easily made. And there's a lot of factors that patients are considering. And we have patients that, they may have undergone, the medical interruption procedure, but they still grieve. They still grieve. They're grieving the loss of, of their child. And, some have required extended, postpartum care and things like that. But we acknowledge that this is not an easy decision for these families to make. And we support them on their journey no matter where that leads. And I do have to say, it's our program, it wasn't always this, robust and comprehensive. I mean, we did, you do have to start from square one and then learn as you go and then slowly build out. So I'm very proud of where we are now, and just, happy to connect with, other centers and collaborate and help other places grow. But one of my passions is mental health and support, and so that is a big area of research that we are looking into and developing. But I so appreciate you joining and applaud you for sharing your story and being so open and just acknowledging that the journey that you went through. And I'm sorry that you had to do a lot of that on your own, and unfortunately that's just where we are at with our healthcare system too. Like I said, a lot of patients, they'll just call us directly. We found you online. We don't know what to do. What do we do? And even if they don't end up coming our way, we still chat with them. We get to know them. We try to help find them resources in their area. So it's a lot. And yeah, I'm so glad you joined, and yeah, really appreciate you sharing your story.
So, Alex, I'd like to actually add a little something that I think
Hmm.
we haven't talked about a lot, and that is memory making for
Hmm.
families who have made the courageous decision to end a pregnancy. The other piece of that is often these are very wanted babies.
Yeah.
This is an incredibly painful decision. But what we also try to do is if that is the route, we want to
Hmm.
empower you with tools on how
Yeah.
you can document your family experience. You can honor this baby with memory making, with naming, whatever that
Hmm.
is. And so I think that that's really important for these families because I think they're very silent grievers.
Yes. Yeah. Absolutely. Absolutely.
More questions for Alex? Okay. Well, Alex, it was great. Obviously, I work with you and
Thank
I see
you.
the
There's a
great work
question
that
in
you
the
do.
chat.
Oh, sure.
Oh, you did?
Sorry, someone doesn't have a microphone, so
Oh,
someone put a
that's
question in the
okay.
chat.
Okay.
Yes. Yes.
Oh,
Okay.
good.
So, yes, Mary Grace. So their health system has a level 4 NICU, level 4 OB, and primary maternal fetal medicine practice, as well as a community pediatric palliative care program. So it looks like her role is chaplaincy, and that these systems are sometimes working in silos. Yes, absolutely. That was one of the biggest barriers that we had to overcome, and Gina can attest to that, especially when it comes to a specialty. Everybody is very good at what they do, but at the end of the day, these patients need all the support they can get. It's so important to try to connect. Um, and so maybe the best way about going about that is like maybe finding a contact, from each team, whether it's a nurse, or a manager, or whoever like their primary, like, point of contact is, and just trying to come together in like more of like a strategic meeting setting, and even having some patient examples. Sometimes we learn from you know errors, mistakes, or missed opportunities, and coming together with some examples of how can we do better, and showing the importance of working together as a team and trying to find some middle ground, especially for the chronic and palliative care. I know we used to, like I said, we used to have to walk those birth plans over to the hospital when we had different systems to make sure that these patients' plan of cares made it over. And it was hard to make sure everybody was on the same page. But for the Journey program, Gina, I helped identify this need and, reached out to me, and we all had to come together. And, we started small, but, it is possible. It is possible. You just have to start small and making those connections and coming up with an ultimate goal, and then just using those patient examples, like I said, of how can we do better and showing the importance of that partnership. Because at the end of the day, we all want the same thing, and that's to give the best patient care and to minimize the stress and complexities of the coordination. Yeah. But feel free to reach out to me. I'm happy to also too, if anyone wants to, email me or just, further communicate or chat. I'm more than happy if you want to reach out and further discuss and go from there. But I appreciate you all very much for joining and listening and sharing your feedback and asking your questions.
Thank you, Alex. It was
Thank you.
great. I want to really thank you for your willingness to present this topic, because I think a lot of people don't have a
Absolutely.
lot of information regarding how a fetal center works, but also knowing how they work and the complexities. It prepares, it gives us on my side a
Yeah.
better kind of a lens into how to best care for them once they get to us.
Yeah,
So
absolutely.
I want to thank everyone. We're kind of out of time. I want to thank everyone for joining us today. And especially Alex. And I hope that we can see you in New Orleans in May for the International Perinatal Bereavement Conference. I am so excited.
It's an incredible conference. Yeah.
The first time I went, and I've never missed one since. The first time I went, I felt like I was home.
Yeah.
I was surrounded by my people, and I just sucked in all that knowledge and expertise and left it. So I hope you'll join us. Anyway, if you have any questions, please feel free to continue sending them our way, and we'll make sure that we get them answered for you.
Absolutely. Thank you
Take
all
care.
so much.